Hi, and welcome to the Cerebral Palsy Foundation New Horizons Town Hall. We are so excited to be continuing this free educational series to educate families and individuals with cerebral palsy about the latest updates and overall management of CP. Now, today is very special because it is actually the 15th anniversary of National Cerebral Palsy Awareness Day. And so we would like to encourage all of you to go green for CP. And we're really excited to be bringing you this town hall today. This was made possible by Ipsen Biopharmaceuticals. And now I am excited to actually introduce you to the panelists from Scottish Rite for Children and the University of Texas. And I will bring them all on for you now. And we are really fortunate to have such an incredible team joining us today. As I said, they are from the Scottish Rite for Children's Hospital and UT Southwestern Medical Centre. And first, I'd like to introduce you all to Dr. Mauricio Delgado. Mauricio is the Professor of Neurology and Neurotherapeutics at the University of Texas Southwestern Medical Centre in Dallas. He served as the Director of Neurology at Scottish Rite from 1990 to 2017, and his clinical and research interest on child motor disorders led him to establish specialised clinics in cerebral palsy. Dr. Delgado, it's so wonderful to have you here today.
Thank you, Rachel.
Next up, I want to introduce you to Dr. Fabiola Reyes. And Dr. Reyes is a paediatric rehabilitation medicine physician in the Neurology and Rehabilitation Medicine Department at Scottish Rite. She treats the motor control patient population, and her clinical interests include visual gait analysis, goal-directed tone management, and the multidisciplinary therapies to maximise function and participation in children affected by cerebral palsy and other physical disabilities. Thank you so much for joining us today.
Thank you.
Next, I'd like to welcome Dr. Lane Wimberley to the panel. Dr. Wimberley is a full-time paediatric orthopaedic surgeon, and he's the orthopaedic director of the Cerebral Palsy Program and the medical director of the Movement Science at Scottish Rite for Children's. We're really fortunate to have you here today because obviously you balance a very busy clinical environment with the support of research and education as well. So thank you for joining us.
Thank you for the invitation.
Of course. And finally, but definitely not least, Dr. Veronica Meneses is a developmental pediatrician, and she works in the Pediatric Development Disabilities Department at Scottish Rite for Children's. Her clinical interests include conducting evaluations for children with complex medical conditions, including vision and hearing impairment, and providing a continuity of healthcare for children with all different types of developmental disabilities and complex medical diagnosis. So thank you so much for joining us today.
Thank you. Thrilled to be here.
So we're really excited. So we're actually probably just going to get into it. Now, there's a few things that we'd like to sort of do for housekeeping at the very beginning. Please, if you've got any questions, put them in the chat box. We would love to obviously answer as many questions as we can today. So please, if you've got any questions for any of our panelists, ask throughout and we'll try to answer those for you. The other really exciting piece that we've got going on today is that we're also going to be presenting this panel in Spanish. And I'll hand it over to Dr. Delgado just to explain in Spanish what we're actually planning on doing.
Thank you, Rachel. Bueno, vamos a tener la oportunidad hoy de tener en la segunda parte de esta plática la misma información que vamos a dar en inglés, pero la vamos a dar en español. Así que si usted no habla inglés, no se preocupe, espérese media hora y vamos a poder entonces platicar con ustedes también.
Thank you so much, Mauricio. So for those of you who don't speak Spanish, we are actually going to, as I said, be having this town hall both in English and Spanish. And so after we do it, it's going to be absolutely repeated in Spanish. So please, for our Spanish-speaking audience, hold on and we'll be doing that part of the town hall with you shortly. So I think actually we're just going to get straight into it. And actually, Dr. Delgado, I have some questions for you to begin with. So if we're thinking about cerebral palsy, obviously one of the first questions I think we really should answer is, what is cerebral palsy and how is CP diagnosed?
Yeah, thank you, Rachel. And thank you for the invitation to be here with you.
Of course.
especially on this special day. So cerebral palsy is, first of all, is not a disease, okay? It's a term that we use to include multiple disorders that present with alteration of movement and posture that are due to a brain lesion or brain abnormality that is acquired during the developmental stages of the brain. So that means before birth or infancy. Mm-hmm. And this abnormality in the brain is stable, it's not progressive. So it's going to be always the same. The manifestations of this lesion or abnormality in the brain may not be necessarily stable. Patients may get it better or may get complications from the abnormal tone and abnormal strength that they may have in their bodies. So cerebral palsy is not one thing, it's many things, and not only affects movement and posture, but can also produce other problems. And we'll talk a little bit more about that, I hope, later in this conversation.
Yeah, absolutely. So, on that, if we've got families who are watching today who maybe have concerns for their child or are thinking they're maybe not meeting their developmental milestones, what are some of the signs and symptoms that they should be aware of?
Yes. So I think in the majority of the cases of patients with cerebral palsy, at the very beginning, in the first 3 months of life, may not be nothing that they can see. But as the child starts getting older, and then they start observing that they are not developing, they're not having the milestones, at least the motor milestones, following what other children do. So around 6 months of age, they may see that they're not moving one arm, or they're not crawling the way that other kids do, or they cannot roll over, they cannot sit up, and then they start seeing these abnormalities. So basically, they go to the pediatrician, and the pediatrician then is the one who's going to decide if this kid is following normal development or not. And then from there, they will be referred to the specialist, which is going to be a neurologist or an orthopedic surgeon or developmental pediatrician. Usually that's the way it goes.
Thank you so much, Dr. Delgado, for that sort of description, because I think this is one of the tricky things when it comes to cerebral palsy is that, as you said, it's not one condition. It really is a spectrum of lots of different things, and obviously everyone really presents very differently. And I think this is where sort of my next question comes in. And Dr. Reyes, I'm going to actually have this question go to you. If we're thinking about cerebral palsy and everything looks differently, what are some of the types of cerebral palsy that we see and what it looks like? Oh, I think you're on mute.
We can't hear it.
Thank you.
No problems.
Very good. All right. So, when I'm thinking about the types of cerebral palsy, I'm thinking about the classification we assign. And so it's going to be based on either, topographic or anatomic description. We also classify it or describe it based on the motor difference that we see. And then a lot of times we also want to make sure we use a descriptor to really look at the functional level of the child. So I could go into that a little bit more in detail.
Yeah, that would be wonderful. And I know that we've got some photos to share today as well that we're hoping people will be able to see. And so this one that we're looking at right now, can you help describe what we're seeing in this video?
Yes, so I'm going to see, this is a description. I'm going to go over the description of hemiplegic cerebral palsy. So hemiplegic cerebral palsy means that one side of the body is affected. And so both the upper and lower extremity of the body is affected. And so as you see this little kid who's walking, he has difficulty placing his right foot flat on the ground. And then when he's moving his arm, his right arm does not swing the same as the left arm. And so that gives us a clue that both, the right side of the body is affected by the motor disorder.
And how common is sort of this presentation or this sort of movement disorder that you may see?
So it's I don't have the number off the top of my head. Maybe Dr. Delgado does, but usually we see this type of presentation when there's a specific lesion on one side of the brain. So other types of presentations may show more diffuse involvement, whereas this is going to show, for example, some sort of evidence of maybe an ischemic insult, so lack of oxygen to the brain, to one very specific region.
And so I think we actually have another video that we will put on. And can you start thinking about how to describe this next video? Like, what are we seeing here and what's the differences? And maybe what are the differences that you would see in, say, an imaging or an MRI compared to the child before?
So this child, and I apologize, I don't think we see the hands and the upper extremities very well, but this child has what we would describe diplegic cerebral palsy. So that means that both of the legs are affected with the motor disorder. And so, one of the things you see here, and I could go into this a little bit more later, you see the shaking of the legs, which we call clonus. And that is a manifestation of spasticity, which is one of the components of the motor difference in cerebral palsy. The other thing we see, and I wish you could see it better, but this child's able to really use her hands really well to hold on to the walker. And if you were able to kind of ask her to do certain things with her hands, she'd probably be able to use them pretty well equally. As she'll have a hand dominance, but use both hands pretty well. And even though there might be maybe some subtle fine motor differences in diplegic cerebral palsy, the part of the body that's mainly affected is the legs.
And so this next one, now that we're going to be reviewing this sort of next video, can you sort of describe again what we're seeing here and the differences, I suppose, because obviously this individual is no longer using a walker, but potentially looks like they have involvement in all four of their limbs.
That's correct. So this is a very good example of quadriplegic cerebral palsy. And so even though this child is not using a walker, she does have some differences of movements in both legs and also both arms. And we'll talk again about this a little bit later, but one of the things that I do notice when I'm looking at this video is that the movement is probably having a component of dystonia and not just spasticity.
Okay, so that's really interesting when we sort of now talk about the different sort of types, I suppose, of what we're seeing. So the first two videos were showing spasticity and tightness in the muscles. And I think we've got your next video now as well, survives that and it will shows that a little bit more. But can you go into a little bit more detail about what spasticity actually is and what it means for somebody's muscles and for their movement?
Yeah, so when we're talking about the different types of motor classifications or the motor differences that we see in CP, I like to group some of them into hypertonia. So hypertonia means that it's a tendency of muscles to be tight. Within the hypertonia category, I think about it as either having dystonia or spasticity. And spasticity really is a muscle tightness that's consistent, that really occurs when the limb is stretched or the muscle is stretched, and you feel a catch and release. As you saw in the video, when the limb or the knee is extended slowly, there's not a catch, but when it's extended quickly, you'll see a catch and release, almost like a clasp knife mechanism.
And then so we sort of spoke about, okay, well, this is sort of what spasticity could look like. And you mentioned the word dystonia before. Can you sort of now describe a little bit more the differences in those two?
So spasticity is consistent. We will see it even when the kid might be asleep or when they're relaxed, regardless of emotional, their emotions or their intent to move. Whereas dystonia is more variable. And we could see a really good example of this here. So we have this child who his toes start curling as he starts reaching and picking up the snacks inside that bag. And so dystonia could be variable, and it's really an unintended muscle movement. Mm-hmm. And when he's relaxed and he's not using his arms and his upper extremities, those toes relax as well. But once he starts moving those hands to try to focus on really grabbing those snacks, you see that the toes start curling. And so those toes curling is an unintended movement that is descriptive of dystonia.
And are there any other types of different sort of movement patterns? I'm not quite sure we have any other videos, but are there any other types that you would sort of that we see?
Yeah, and I make sure to always, let families know that these are probably the most common types of tone differences we see, but we could also see hypotonia. So that means that it's going to be a tendency of muscles to be more relaxed than they typically are. We also see ataxia, which is really a difficulty with balance. So you'll see balance in the trunk being a little bit off, or even difficulty with performing smooth limb movements. And that's typically when the cerebellum, the portion of the brain that really helps control smooth body movements, is affected.
So I think you sort of touched on that a little bit as well. So all of these components and what we see sort of with the motor presentation does actually relate to where the injury or the issues are within the brain. Is that correct?
That's correct. I forgot to mention, for example, for diplegic cerebral palsy, we will typically see what we call periventricular leukomalacia. So it's scarring around the ventricles, the area of the brain that holds our spinal fluid. And usually we see that when we have diplegic cerebral palsy and we have spasticity. The spasticity and dystonia component could be very subtle. So we have very specific tests that we do in clinic to make sure we're able to differentiate those two.
And so when we're thinking about, obviously now, different motor types, you said there's some other different ways that we can start thinking about and describing someone's cerebral palsy as well. And this is from thinking about the motor components. Here on the left, there's sort of a graphic here in relation to what we would call the gross motor function classification scale. Can you just describe that in a little bit more detail?
Yes, and so we use the scale. It's really a useful tool, especially for clinicians, to be able to, communicate the different abilities and different functional movements that individuals have in different environments. And so it really helps us not only tailor specific treatments, but it also helps us kind of look into the future and see what changes we might expect in the future. We use the gross motor functional classification system, so we call it GMFCS. And GMFCS 1 level, this classification describes individuals who could walk very well in all types of surfaces with no or very little help. Typically, these individuals could go up and down the stairs without holding onto a handrail. For GMFCS level 2, so this classification describes individuals who may have a harder time and may need a little bit more help with walking on uneven surfaces. Typically, I ask families, could the child go up and down the stairs? Do they need to either hold on to somebody or to hold on to a handrail to be able to know if they fall under this classification? And then level 3 is the classification that describes the individual who might use an assistive device to walk shorter distances, but may need a wheelchair to walk longer distances.
And obviously the pictures or the images that we're seeing on the left are just examples, because obviously, as we've already heard from Dr. Delgado, everybody is so different and presents differently, and obviously how cerebral palsy affects them is different.
Yeah, and the other thing to keep in mind too is that there are different age ranges where we expect kids to do certain things developmentally, whereas there's other age ranges where we don't expect them to be doing things. So, for example, an 8-month-old might not be walking, and so we don't use the overall GMFCS systems to classify mobility in that child. We would use one that's called the GMFCS extended and revised version, which really helps us understand what kind of mobility and growth milestones we should be expecting for that level, for that age.
And so I think this is actually a really nice segue to invite all the other panelists back and sort of talk about, obviously now we've spoken about diagnosis. We've seen how it can affect everybody from a motor perspective, but there's obviously a lot more when it comes to cerebral palsy. And Dr. Delgado, particularly if we're thinking about, how we look at different things and how we decide on what the best treatment is or what the best process is forward. Could you just elaborate on that a little bit further on what you would do? How would you set goals with a family? How do we go on from here once you've got a diagnosis?
Yes, thank you, Rachel. I think it is important, number one, to understand that, as mentioned before, that cerebral palsy it's arising from an injury or a lesion in the brain, and depending on what part of the brain, then the type of manifestations you're going to see. So besides the motor aspects, the patients may have other problems, other impairments, epilepsy, cognitive impairments, speech and language problems, hearing problems, visual problems, and others. And so it's important then to understand that we need to make a very broad and careful evaluation of the patient by a multidisciplinary team, so we can assess all these different impairments or challenges that the person with cerebral palsy may be presenting with. So how do we decide about managing the patient with cerebral palsy? Well, first of all, I think we need to be sure that we understand that it's cerebral palsy, what is the cause, that we're not dealing with something else. So the diagnosis is well established. And then we need to have a conversation with the family, with the parents, with the patient, if possible, to understand what their goals are, and start trying to put the treatment or the management together in order to help them achieve those goals. Because the patients don't come because they have a spasticity or dystonia. They come because they cannot participate in activities and play with other kids and attend school the way the other kids do. So I think we need to make sure that we do a good assessment and then have a conversation to see what are those goals for the management of the patient that we are seeing by the team.
So I think it's pretty broad, right? So I think whenever we're thinking about now this sort of planning and how to put it all together, Fabiola, could you just describe a little bit more then about along the age span and the spectrum and the different, how it all varies? Because I think sometimes it can be quite confusing for families when they're trying to navigate this system, and how do we look at knowing what should be done when?
Yeah. So I like to think about the different stages, maybe in 3 major stages. First, I think about the period between infancy and about 6 years of age. And at that time, really, this is a time of really rapid development. And so I like to really focus on development and facilitating as much development as we can. So, for example, I'll start looking at ways whether milestones are being met for both fine motor, gross motor, oral motor, and identifying any impairments that might benefit from therapy. So that's really the main thing that I look at during that period of infancy to about 6 years of age. At that point too, we tend to favor more non-surgical interventions for, musculoskeletal differences. And so at this point too, I'm looking to see whether tone interventions might help, such as botulinum toxin injections, casting, or bracing. Then after the period of infancy, we're looking at about the period between about 6 years of age to like maybe middle adolescence. And at that point, it's a period of rapid growth physically. And so we want to make sure we're keeping track of the musculoskeletal differences really that are associated with these periods of rapid growth. So that's where Dr. Wimberly really comes in, and he's really monitoring and following the kids very closely to see if there's any interventions that could help with function or comfort. That's really for about 6 years of age to middle adolescence. And then, from middle adolescence and on, we really want to make sure that we're setting up the kids with the right tools and gearing them up for transitioning into their adult life. We want to make sure that they're as independent as possible and that we're providing the resources that may help them succeed in the future, whatever that goal may be or whatever success might look like for them and their families.
I think you brought up a really good point, right? So obviously, and we'll go into more detail into some of the surgical, non-surgical interventions and those different things that you can do a little bit later. But Dr. Wimberly, if we're talking about orthopedic surgeons particularly, obviously you don't have to operate every day. Like there are other things that you do.
Yes.
And so could you just sort of describe a little bit between what might be considered surveillance or sort of what would be potentially an annual checkup to when you would actually then do an intervention or think about surgery?
Sure. So I'm very lucky in the sense that I get to work with this panel, and we do multidisciplinary type clinics. So some of the surveillance isn't necessarily by me, but it's by our team. And what we're typically watching for in the realm of surveillance is the child's function, or is the ability of the caregiver to provide for the child changing? So perhaps a child who needs to wear a brace to provide them some stability when they're walking around or provide support to keep them functioning well doesn't fit anymore. The reason the brace may not fit isn't because they've grown, but it's because their foot position perhaps has changed. Mm-hmm. Maybe they have developed a contracture, so a true loss of range of motion at a joint that is now inhibiting their ability to use devices that they really need for proper function. And when we see those sorts of changes, that can be an indication that perhaps it's time to consider a surgical intervention rather than allow continued modifications to bracing. We, as Dr. Reyes has discussed, we do classify children as to their level of function. And that's not meant to put them in a category that defines them in any way, but it helps me decide what our goals might be. And as always, goals need to be shared by the caregivers, the patient, and the patient's family. And so children that are running around and playing soccer with a very small neurological impairment might have a different goal than a child who really relies on a wheelchair for all mobility. And so we continue to work with the family and the patients to determine perhaps is there an intervention orthopedically, a surgical intervention that may allow them to be better in their quality of life.
And I think, you bring up a really good point with thinking about this individual goal setting. And I think it's just such an important piece that, whenever, and please, if anyone has any questions, make sure you put them in the chat function. But when we're thinking about this individual goal setting and how to have this shared decision-making and this, I suppose, two-way dialogue, there really should be families and children themselves should really be involved in their decision-making pathway when it comes to their care.
Without a doubt. It's almost several times a month, there'll be a 8 or 9 year old child who probably would benefit from surgery, but has no interest in it. And I kind of tell the families, I can't hold your child down and do something to them, especially as they get older. They will ultimately, hopefully, understand consequences and what may or may not benefit them. But yes, we involve the child, the patient, as much as possible in decision-making. And unfortunately, there are cases where that's not realistic and the families make decisions for them. But we must all agree on the goal. And the goal has to be not only realistic, but attainable with a safe procedure.
And so I think, as I said, we're going to go into a bit more detail later about some specific interventions. But we've all touched on this piece that, cerebral palsy, yes, has motor components and presentations on what we see, but obviously it can affect lots of different parts of the body. And so, Dr. Meneses, what are some of those different areas that we see children, how it affects them?
Thank you. Yes, I think that feeding and nutrition are very huge concerns that affect really every part of the child. Obviously, physical health, but can also make the child have less energy to participate and be included in school and in community type of activities. And it can also make it more difficult for the other interventions that are being recommended to really be optimized. For example, if Dr. Wimberly wants to do a surgery on a person with CP and their weight is very low or they have aspiration, then we're going to have to address those issues so they can have a good surgical outcome.
And so if we're going to sort of think about, and we've got this next diagram that's coming up, showing, I suppose, a body system. Can you just sort of explain a little bit about the components on here? Because it's everything from the mouth, obviously, all the way through the digestive system.
And really it's showing that muscles are really moving this system of digestion and this mechanism of swallow from the muscles in our face and our neck that help us chew and guide the bolus of food down to the tube that connects the mouth to the stomach, which is the esophagus, and down further through the intestines where all the nutrients are being absorbed that are going to give the child energy, like the proteins and the carbohydrates. And even as you're forming the waste products and having to expel them from the body, those are muscles that are bringing this about. So we saw in the videos, the muscles that are involved in the gross motor activities very affected. But I wanted to highlight that there are also muscles that we can't necessarily see that can affect things like feeding, that can affect things like speech. They're going to have large impacts on the person with CP in many dimensions of their life. And when we see this kind of thing, we want to evaluate and see how we can make things better.
You've got the word dysphagia on here. Can you explain what that is?
So the dysphagia would refer to the problems that a child can have to chew and to swallow and to really directly swallow food and liquid from the mouth into the stomach. And some people with CP, they can seem to cough or have to clear their throat, or they can have sort of a gagging reflex that will indicate that that process is not working as smoothly as it should. In the more severe cases, we may have a process called aspiration. And that's where the food and liquid particles are actually entering the airways. And that can cause problems in the lungs like pneumonia, bronchitis, and congestion, which can cause illness.
So I think when we're thinking about, feeding and nutrition, obviously it is such an important part of all our lives, good nutrition and how important that is. But it's not just one specialist that you see. You mentioned, okay, there's lots of different muscles in our bodies. Can you sort of describe some of the people that you might see on the team if you're thinking about some of these other issues that you might see?
Right. And I want to point out, firstly, that the child and the family are in the center, just like all of you have mentioned, because the priorities and the values are really going to guide us in terms of the evaluation and the interventions. But we have the speech and language therapist who's really an expert in how that swallowing mechanism occurs, because the same muscles that are helping us achieve speech are helping us with swallowing correctly. We have pediatrics or developmental and behavioral pediatrics and nursing to help to integrate the findings with the medical plan and communicate it to the other people on our panel who are working with the family as well. We have occupational therapy who are really helping with the positioning, like positioning of the head and the neck. That is really crucial to be able to make sure that it's a safe kind of a swallow, and are helping with the seating and the alignment of the trunk and the hip that can also really cause either stability or instability in the swallow. Nutrition, dietitian is very important. Children with CP and people with CP, depending on what their level of involvement is, will either burn a lot of calories because of spasticity and movements they can't control, or the movements may be more diminished and they may be burning less calories. So we have to have a nutritionist with experience to be able to calculate what's appropriate for that child. And finally, but not last, a child life specialist, because we want the child to understand what interventions we're doing, what the procedures might be, whether that's observing them while they eat, so we can make some detailed clinical kind of observations, or doing an X-ray with contrast so we can follow the bolus as it goes down. We want them to feel comfortable and have an opportunity to be kids and play, even in the clinical setting.
So I think, this is obviously an example of a multidisciplinary team for an issue around feeding and nutrition, but this is very similar depending on whatever the goals or whatever potentially the intervention is that child will require.
Mm-hmm. Yes, and that's why we wanted to include that, because it's kind of a example of what a multidisciplinary team can, accomplish, and the different perspectives that can be brought to play in working with the family and the child. And
we've just had a question come in actually around how early should a care plan be put together? So if we're sort of thinking about, these different pieces, how is there any stage that would be too early, or should really a care plan be put together as soon as these sort of goals have been identified or a diagnosis has been made?
Yeah, I think the earlier, the better, for sure. And understanding that sometimes in the early years, we're waiting to kind of see what sort of some baseline things will be, waiting for maybe certain things to stabilize. But I think it's important because in creating a plan like that, you're able to really get to know the family that you're going to be following. As we are fortunate to follow families and children over the long term, you're able to really get to know what is important for them, what drives and motivates them. And that is going to really be crucial to us in choosing both evaluations and interventions and therapies. Thank you.
And I think one of the really important steps here as well is to think about that this care team and this team isn't just within a hospital setting. This really should be within a home setting as well. And this slide, could you describe the example here of going, okay, so this is still for potentially a feeding and nutrition goal that they might have, but how important the home environment is in actually achieving those different pieces.
Absolutely. I think that, with, these clinical diagnoses and coming to a specialized center, there are a lot of interventions that are very, specific that are recommended, the different therapies and whether there's evidence for the therapy. And that's all really important and great. And we definitely want to continue to read the research and see what are the best interventions. But we want to really emphasize the time with family and with loved ones, in that home setting where there's love, there's affection, there's understanding, also counts as a therapeutic type of time. Shared meals, music, books, art projects at home, going for, trips through the park and through the neighborhood and getting to know the community, learning how to care for pets and interact with pets. As well as, church inclusion activities and other community groups in the wider community, so that the child world is expanding as he or she grows up, and he or she is feeling like they're a part of that and they are contributing to that. That is something that is going to have a lot of positive benefits.
And so I think now I'd actually like to invite the whole time back. Because obviously we're sort of about a lot of different things and we're getting lots of different questions coming in as well. So I'd like to just dive into a little bit further around some of the actual specific interventions. We sort of have touched on it briefly, but Dr. Delgado, can you talk about some of the more specific treatment management considerations that we would have, for example, the non-operative and operative management considerations?
Yes, so the non-operative strategies that we have to help a person with cerebral palsy achieve his or her goals can be considered if you want, as treatments of symptoms, okay, or trying to treat the symptoms, because we don't have a cure for cerebral palsy yet. So, so what do we treat? So weakness, how do we address weakness? Palsy means weakness or paralysis. So cerebral palsy means weakness or paralysis due to a brain problem. So I think that is an important issue, and that's where the therapists are going to get in. They're going to help us strengthen, improve range of motion, improve balance, coordination by different therapeutic strategies that they use. Tone is another issue. So we already talked about spasticity. We talk about dystonia. How does it affect the patient? Does it cause discomfort, pain? Does it interfere with the use of a brace or a device that we are trying to get the patient to utilize? Is it interfering with leg crossing, walking on their toes, getting a hand that is fisting, or a wrist that is in excessive flexion? So managing tone is an important aspect of the treatment, and that's where we can do something about, okay? So there are other things that perhaps we don't have too much of a treatment for. For this, we can certainly help. So if the increased tone, either spasticity, dystonia, or both, are affecting, a few muscles, we can consider botulinum toxin, certainly, and we can certainly combine that with other aspects of the treatment, because we never use botulinum toxin in isolation to treat the patient with cerebral palsy. So we use it in combination: bracing, casting, stretching, strengthening, and so on. So botulinum toxin is one thing that we do a lot in those patients who require the management of spasticity in order to improve function, reduce pain, improve posture, etc. Other treatments for tone include oral medications. We have some oral anti-spasticity medications that we can use, anti-dystonia medications. We can use intrathecal baclofen for some patients who have a more generalized type of hypertonia. So those are the main non-surgical type of treatments for the hypertonia part of the patient. And there are many other things. So if the patient has seizures, we need to control the seizures. If the patient has behavioral problems, we may need to manage those behavioral problems with therapy or medications and so on. So the non-surgical part of the team gets very busy by managing all these aspects, and then surgery comes in as one of those treatments that may help us improve things that with medicine we can't, like bone alignment, joint scoliosis, etc., that Dr. Wimberly can talk more about.
So I think, we talk about treating the symptoms, I suppose, was what you just mentioned. Is it possible, though, to actually have changes in the brain as well? We've heard that obviously the injury or the reason for cerebral palsy is because of the brain. How do any of these treatments actually then end up leading to changes in the brain?
That's a very important question, and I think that's why the answer Dr. Meneses gave you earlier. The earlier, the better, because neuroplasticity is actually more florid, more abundant in the young child than when we become adults. I mean, so we still have neuroplasticity, but not as much as when we are.
So I think that brings up a really good point, like thinking about through the lifespan.
Helping that brain. Yes. So so we've been talking here just for children, but we need to talk about.
Well, I think your connection might be dropping in and out a little bit there. But when we're talking about, I suppose, transitioning to the teen years and through to adulthood and things like that, obviously, these interventions are still very important, and what could be available. Dr. Reyes, what are you seeing there, or what do you recommend, or what is available in the teen years? Is it similar?
So, we're in the teen years, especially Dr. Wimberly, Dr. Menezes, Dr. Delgado, they're still going to be managing those active, orthopedic differences, feeding differences, behavior differences, or neurological differences. So we want to make sure that so as the child transitions from adolescence to adulthood, that we find providers and people who are going to be able to continue to maintain that holistic care for the adolescent. Transitions too is a big thing that we're working on at our institution. And one of the things that we want to do is make sure that the adolescent really has the tools to be able to meet their goals when they're adults and they're going to be more independent. So we have a psychologist actually and our social worker. We have a program where we make sure that every year in the teen years, they're meeting with the adolescents to talk not only about strategies to help the adolescents become more independent, but also how to navigate that system. There's some people and some individuals who may need a little bit more help, for example, with making financial or medical decisions. And so we make sure that we have all those systems in place so that if that's the case, once they turn 18, they're able to have the either guardianship or the legal support to be able to have somebody help them make decisions.
And so this is a question that's actually just come through, and it's about putting together the care team, putting together this plan. Like, who should do that, and is it different at different organizations? I know previously sometimes it was the orthopedic surgeons who actually managed the care the whole way through, and obviously we're seeing a shift in bringing in a more multidisciplinary team. But who usually actually puts together these sorts of plans and these care teams?
So at our institution, we do have multidisciplinary clinics, so we're all able to work together to really put these care plans together. We do have our patients are referred to us from the orthopedic side, so they're the ones who initially and just from the very get-go come up with a plan and then start referring when it's appropriate. Mm-hmm. I don't know what your thoughts are, Dr. Wimberly and Dr. Delgado and Dr. Menezes.
I agree. Our institution is a little bit unique in the sense that most of the patients come through the orthopedic clinic first, but that doesn't necessarily mean that we are the ones driving care exclusively. As Dr. Reyes alluded to, it's not overly common for children to need a surgical intervention before school age. And we have children who are younger and still need to be observed for challenges that may arise in the younger child. But the need for orthopedic intervention may not be several years after they arrive to our clinic. And so when you talk about plans, I think we have a strategy for management of children, but we also have to taper that to each child and the family's needs and goals. And so I don't know that we are prescriptive, but instead adapt to the changes in the child's abilities over time.
I think that's a really good point, right? That is sort of, rather than being prescriptive, there is no recipe, there is no exact plan that a family will follow. It's just more having an overview and knowing who to have come in at the right points. And I think that's wonderful to have a multidisciplinary team like you all have at, obviously, down in Texas, is because it allows for that. It allows for this sort of feedback and interventions and obviously what we would really call shared decision making.
Yeah, can I add something, Rachel?
Absolutely.
Yeah. Hello, Rachel. Yeah. So I think it doesn't matter who takes that role of coordinating the care, as long as somebody does it. I think it's important that, sometimes it's the physiatrist, sometimes it's the developmental pediatrician, sometimes it's the neurologist, sometimes it's the orthopedic surgeon. So I've seen this in different settings, but it's important that somebody takes responsibility to coordinate the care, because there are so many so many aspects to the care of a patient with cerebral palsy that it's important that we don't drop the ball somewhere. And obviously, the parents are an important part of this team. And many times, parents end up taking a little bit of that role too, coordinating care, especially when there is a void, when there is nobody taking that responsibility. So I have parents who are absolutely amazing in how they keep track of everything that's going on with the child. That's all.
And I think it brings up a really good point that somebody's asked as well, is how can they find out more information? And I think this is always a great question, and we love to hear it because there are places where you can find more information. Obviously, there's all the resources that your team have, and we'll be sharing this with, obviously in the chat function, but we will be sharing it with everyone who's signed up today, all the different resources that your team's created. We also have cerebralpalsyresource.org, which has a huge amount of resources from, across the lifespan, looking at different components as well. But sort of a question that sort of is coming in is talking more specifically about spasticity and how it's treated. And now I'd actually like to invite Dr. Delgado and Dr. Wimbley to sort of talk us through actually an example of what this could look like. We've got a video that you've shared with us, and I'm pretty sure this is before any intervention that we're seeing this child walking. But when a child comes into the clinic and they're coming in and they're seeing these different things, Dr. Wimbley, what are you first noticing? What are you starting to think about when you're like, all right, what interventions might be appropriate?
Sure. So first of all, what you're seeing is the video of a child in our clinic. And it's important that when you evaluate these kids that you have them walk, and you can see they're in shorts and their shoes and socks and braces are off, and we have them as unencumbered as possible. And you need more than walking in a room where they take 2 steps. So if you don't have a space within your clinic, you take them to the hallway. You need to really see what their adaptations to their walking pattern might be to have an idea of what impairment they may have that could benefit from a surgery. When you look at this, it's a small video of a child with hemiplegia, it appears, that's walking up on their toe. And that walking up on their toe may be what we would consider dynamic, in the sense that there is some tone that we've discussed that keeps that foot in that position, or there may be a contracture, at which point there is truly a limitation of motion, and no matter how much you push on that ankle, there's no way to put it flat, or it may be a combination of the two. And spasticity management, as Dr. Delgado and everyone has mentioned, is imperative to have a good surgical outcome. So if we just operate on everyone that has an impairment but don't affect their tone, then overall the surgical success rate is going to be less. So in this young child, if they have a contracture, perhaps surgery is most appropriate to get their foot flat to the ground, but also be aware of what other components to their impairment or their disorder may need treatment.
So, Dr. Delgado, we spoke about before about, like the antispasticity medication, so something like botulinum and toxin. In a child like this, would you think something like that could also be appropriate? And then thinking about the other elements that would need to be done in conjunction with that, because you brought up a really good point before, is that none of these are ever standalone treatments, that there is always, a lot more other things going on as well.
Yeah. So I think I would like to emphasize the fact that when we look at the child impairment, so we are assessing not only the spasticity, we're assessing what is the strength of the muscles that flex the foot, what is the strength of the muscles that bring the foot up. Is there a contracture, as Dr. Wimberly was saying? That means a shortening of the muscle or the tendon that is not allowing that joint to have the range of motion that is required to accomplish that activity. But we need to put that in the context of what is important for the family and the child. So what is the effect that this impairment, this physical impairment, has on the overall function, activity, and participation of the patient? The patient is tripping, the patient is falling, the patient cannot, play the soccer or whatever. So we need to keep that in mind. So whatever we do here at the impairment level, hopefully will have an effect on the participation level. So that's the way we think. We think about goals that are meaningful to the patient and the family, and everything that we do has to be in alignment with that. So yes, we are going to use botulinum toxin perhaps to treat that calf, muscle group in combination with stretching by a brace, or maybe we'll require some casting and eventually may need some surgery. So it's not one simple answer. It's an evolving type of treatment, if you want, a strategy to help the patient accomplish those goals that are important to them.
Yeah, absolutely. And now I apologize before that the video didn't keep playing, but this is sort of the video after an intervention. So after, I would guess, botulinum toxin injections potentially. So now what are you seeing, Dr. Wimberly? Like if you're seeing the sort of before and after, and I apologize, it was a very quick video for the before, obviously. But are you seeing sort of better heel strike? And what is the reason? I suppose we've touched on it a little bit, thinking about participation and activity. But is there even a bigger purpose as to why you would want to do these interventions?
Sure. So just looking at this video, and I apologize, it's pretty small on my screen, it appears as though he has more plantigrade, meaning the foot is more flat to the ground, and therefore the knee is less flexed. And having a foot flatter to the ground implies greater stability. Stability when that foot is on the ground. And so one of the prerequisites for normal walking is what we consider stability and stance. So when your foot is on the ground, do you feel comfortable that it will accept your body weight as you move forward? And obviously a foot that you're walking on the toes is much less stable than a foot that's flat to the ground. And that can result in reduced tripping, reduced falling, better brace tolerance, and overall just a better gait pattern that's more efficient and more likely to keep up with your friends. So even though prior to this intervention, this child was getting around, probably playing on the playground with his peers without much difficulty, once the foot is plantigrade, that should translate into some improvements in their overall stability and overall gait pattern. And that's our goal, is to ensure that the child is able to take advantage of their abilities and maintain, or not, if not improve some of their functional abilities by an intervention. And if the intervention doesn't provide a benefit that is functional, then you question whether that needs to be done.
Yeah, I think you bring up, a wonderful point. This isn't about, quote unquote, looking better while you're walking. It's actually to improve all these other components so that you can do more. And so these children can do more. And now, Dr. Delgado, this next video shows this child now after, and with this sort of second piece of actually having what we would call an ankle foot orthosis or a brace on as well. Can you just elaborate a little bit more as to what this would now be doing after something like, a botulinum toxin injection, and why this is sort of important, or why sometimes it wouldn't be used?
So the use of a brace, it has a different type of objectives or goals. One is obviously to maintain a joint in a particular position so we can accomplish more stability, as Dr. Wimberly was saying, clearing the ground easier and so on. But also has a purpose of keeping that muscle stretched. And so we can hopefully, prolong the effect of the botulinum toxin injections that we gave to that muscle group. So we believe that when we are maintaining those muscles stretched for a particular period of time, then we're able to prolong that effect of the treatment. So it has multiple reasons why to use a brace, and that will depend obviously on the child. We certainly want to be sure that that brace makes things better, not worse. Mm-hmm. And sometimes we use the braces at night when the patient is asleep, because during the day we don't think it helps that much. We just want it to be there to stretch the muscle in some way. And and so on. So this is just one aspect of the treatment of the patient with a motor disorder like cerebral palsy, and it's important that we have a good orthotist that works with us. That's another member of the team, by the way, that is going to allow us to produce the best brace possible for that particular child with that particular type of challenge.
Yeah, and I've got a question that's come in as well, and it's actually regarding sort of these, I suppose, pre-surgical interventions. Are they always done before surgery? Like, is there, and I suppose I already know the answer to this because we've already answered no, there isn't like a specific recipe that people follow. But are these used to help prevent surgery, or what's, Dr. Wembley, can you just discuss that a little bit further?
Sure. So first of all, there's never a requirement for some intervention prior to a surgery if the child meets a surgical criteria. So for instance, occasionally a child will show up with a 40-degree contracture of their ankle, where their foot just points down to the ground with no hope of getting it flat. In my opinion, there's no non-surgical intervention that will improve that range of motion to an acceptable extent, regardless of age or presentation. And so that may be a time where you just say the best way to improve your gait impairment is with a surgery now. And then move forward after that as the child continues to grow and see what you can do to help them over time. To the second part of your question, do any of these interventions delay or prevent surgery? We certainly see children whose tone is managed well have a lower rate perhaps of needing orthopedic intervention, in the sense that they don't necessarily have as high a risk of developing contracture, which is one of the primary things that an orthopedic surgeon can assist with. I don't know that we can always say a child who has Botox throughout their childhood, regardless of the program, will never benefit from surgery. And we are certainly a lot less liberal with botulinum toxin injections than perhaps historically we have been. I think we find that it's useful for specific goals, but not necessarily a lifelong tone management strategy for these children. So I do believe that there are children that benefit from surgery regardless of age, and I do believe that the pre-surgical strategies are beneficial.
Yeah, thank you so much. And I think, again, what I'm hearing and what I hope, obviously, the audience is hearing as well is that really, it is an individualized plan is going to be the best plan, no matter what you do. And not necessarily comparing your child or your experience to somebody else's. And just because something worked for somebody doesn't mean it's going to work for you. And that really, having this multidisciplinary team is going to be, the biggest priority to working out, what this pathway looks like moving forward. So, before we sort of wrap up and actually move on to the Spanish version, I just wanted to ask the audience if there are any other questions that are coming in. Oh, actually, we do have one, and it's in regards to spasticity affecting the respiratory system. Dr. Menezes, could you just describe that a little bit? I know we sort of spoke about the digestive system a lot, but what about the respiratory system? And you seem to be on mute.
Thank you. Yes. Children and individuals with CP who have more of the spasticity, will have more of the dysphagia and the feeding problems that we talked about, which can affect the lungs through that route, so you can have the food particles going into the lungs and the airways and causing infection and inflammation. But also with more spasticity, with the orthopedic complications that can come with that, you can get a restrictive type of lung disease, which really means that because of the posture and the tone, the lungs are not able to expand to the full extent that they need to be able to aerate the lungs and bring your oxygen in and throw out your waste product. So that would be sort of that connection of why when you're more physically involved with the spasticity, your lung function may be compromised as well.
But is that a common piece? I suppose, a lot of people, there's concerns right now with everything that's happened with COVID and the pandemic. Is it sort of a common piece that you see, or is it, yeah?
I think that it is fairly common. I don't have a actual number for you. I think when there's scoliosis, as I know Dr. Wimberly was talking about, certain types of scoliosis will tend to put more pressure on what the lungs are able to do in terms of expanding. And so that would be a consideration. I think with COVID, individuals with CP and other neurodevelopmental disabilities are definitely in the high risk group, as we think that they could be more seriously affected by having an infection with COVID.
And so I think, I just wanted to say a big thank you actually to everyone. If there's any other questions, put them in the chat box. But really thank you all for taking the time to be on the panel. And obviously it's not over yet, but really thinking about, I'm hoping, I don't know if there's actually an audio. I'm getting a cue saying there's an audio issue. So I apologize if that's happening to anyone. We will try to fix that on our end. But I, really just wanted to say a huge thank you to all of you for taking the time, and obviously everybody in the chat function. And actually, I want to hand it over to Dr. Delgado, who's now going to be moderating for all our Spanish-speaking audience. And I will be leaving you. And I just also wanted to say a big thank you to Ipsen Biopharmaceuticals, who, have really supported this town hall series, and we wouldn't be able to do these without their support. So I will now hand it over to Dr. Delgado to continue with the Spanish-speaking component.